Hi, welcome to the ninth installment of the ASNC interview sessions. Our installment today is titled Expanding Our Diagnostic Capabilities with CZT SPECT. I'm Lane Duvall, joining you from Hartford, Connecticut, where I'm the Director of Nuclear Cardiology, and I'm joined today by Dr. Nieves.
Hi, my name is Ricardo Nieves. I'm the Advanced Cardiac Imaging Fellow at the University of Pittsburgh.
And we are lucky enough today to be joined by Dr. Ron Schwartz, who's a professor of medicine and director of nuclear cardiology and PET-CT at the University of Rochester. He's going to be telling us again all about expanding our diagnostic capabilities with CZT SPECT. Thank you for joining us this afternoon, Dr. Schwartz. I thought we would jump right into things. And could you tell me what exactly is the difference between this CZT SPECT camera and the conventional sodium iodide SPECT camera I have?
Well, thank you, Dr. Duvall and Dr. Nieves, for the opportunity to speak to you today about CZT SPECT. And thanks to ASNC for sponsoring this series. We've been involved at the University of Rochester over the past 11 years with CZT SPECT, and it is a whole technology ahead of what we've traditionally used with sodium iodide. We used to have cameras with 2 or 3 detectors or 1 detector of sodium iodide, and we would do imaging in 17 or 34 minutes in the good old days. Nowadays, with CZT SPECT, because of its miniaturization of the detectors and the use of digital imaging, instead of using photomultiplier tubes to amplify the signal from light, it actually directly converts the gamma scintillation or energy to an electronic signal. And so it's a much more efficient coupling. So CCT cameras have substantially greater sensitivity, as well as substantially greater spatial resolution and energy resolution compared to traditional sodium iodide cameras. So it provides a much wider envelope for considerations of dose and timing. We can use ultra low doses or do super quick imaging or some combination of both that the sodium iodide era of cameras now provides compared to sodium iodide.
That's interesting. So are these new crystals, this new technology, is that the reason why there's a cost difference between a conventional camera and a CZT camera?
Lane, that's exactly right. The CZT crystals are very expensive, and the ability to use many of them introduces great sensitivity for the system, but also increases cost. So in round figures, you're going to pay roughly 2 or 3 times as much for a digital system, CZT, compared to sodium iodide. But the trade-off, I think you'll find when we discuss the applications, is well worth it. It really expands the envelope of what we can do with perfusion, function, and metabolic imaging with SPECT.
So one of the things I've heard actually with applications that have already been touched upon is that, especially in patients, overweight patients and obese patients, that there is an advantage when it comes to CCT imaging as well. In particular, is there anything in particular you could elaborate for us?
Thank you for that question, Ricardo. It is definitely true. We can get excellent quality images in very morbidly obese patients. We actually published a multi-center study years ago and a refined study looking at multi-center outcomes for both diagnosis and outcomes has shown that even in morbidly obese patients with small differences in perfusion, we get prognostically highly accurate information with CZT SPECT. So it really is worthwhile both diagnostically and prognostically. It's great to be able to image someone in less than the usual time that we would have done with routine SPECT imaging and get really high quality images that are both diagnostically accurate and prognostically validated.
That's interesting. So outside of the overweight population, are there other advantages to CZT SPECT compared to my workhorse of a conventional camera that I've had all these years?
Well, Lane, as you know, attenuation correction has now gone beyond the CT application, which you have eloquently talked about in previous seminars. We now have an FDA-approved AI algorithm for effective attenuation correction using the point spread function of the image. And it's been trained upon CT corrected images for SPECT. So it's now available. We're using it routinely now. We find it highly effective. In the vast majority of patients we image, I would say at least 90%, with this, we're finding that we don't need a resting image for stress first. So you can really do stress first, rapid ED inpatient or outpatient imaging in about an hour and be done. So it saves tracer, it saves time, it allows more throughput. So you can almost double your throughput in the lab just by doing stress first. In addition to obesity and attenuation correction, we've been able to use quantitative myocardial blood flow. We've been doing blood flow for over 2 years now. I have about 450 cases. We now have the publication of both diagnostic and prognostic outcome data with CCT SPECT. So it's a growing area that's really very exciting. Certainly PET flow is the gold standard, but in terms of looking at stress flow and flow reserve globally, CCT SPECT looks like it's holding its own for diagnosis and prognosis. The usual functional imaging we do with blood pool imaging, chemotherapy-induced cardiotoxicity, you can measure with SPECT, ERNA or MUGA. Our pulmonary hypertension group here has been using for several years now blood pool imaging of the right ventricle to follow serial changes in right ventricular performance in treatment of pulmonary hypertension. And we've published some studies on that. Certainly you can do phase and dysynchrony assessment as well. We have used here at Rochester, and other centers have done it as well. We've adapted the CEDAR's brilliant approach of dual isotope simultaneous imaging. We used thallium with either pyrophosphate or HMDP. With the lack of availability of thallium, we've actually moved to asynchronous HMDP imaging at 90 minutes, followed by perfusion imaging quickly with sestamibbe. And we're done in under 2 hours with absolutely diagnostic, high quality images that are very easy to read to quantify metabolic uptake consistent with amyloid, TTR amyloid. We've been using for years also the hybrid approach with PET. We've had limited access to PET at Rochester, University of Rochester. So we have actually done our perfusion imaging with this high resolution CCT SPECT. So we save our imaging time on the PET so we can do more sarcoid cases there. We submitted a grant. We're actually gearing up to do MIBG imaging, which has been validated on the CCT SPECT cameras as well. So there's a broad, I think, application for both not only perfusion and functional imaging, but metabolic imaging as well with CCT SPECT.
Well, that's covered a whole lot of ground there. Ricardo, do you have some follow-up questions for Dr. Schwartz?
Yeah. No, a lot of ground, Dr. Schwartz. One of the things that there's been a lot of interest in recently, especially with PET imaging and flow quantification in particular, and SPECT now being able to quantify myocardial blood flow. It'd be interesting to hear a little bit more about correlations or between PET and SPECT flow and where SPECT does fall. It does compare to PET myocardial blood flow, given it's especially the amount of information that we already know about PET myocardial blood flow. So,
well, I must say, Dr. Nieves, we at Rochester have learned a great deal about SPECT flow from you and Dr. Soman from your groundbreaking work at the University of Pittsburgh. And it was through your leadership that we, after you, started doing CCT SPECT flow here at Rochester in February of 2021, and other centers are doing it as well. As you know, the Water Day study that was published in 2018 showed a very nice correlation of CCT SPECT with PET, O15 water PET. And a number of other studies have correlated very highly. Many centers have looked at the correlation with PET. And the correlation in round numbers tends to be in the 0.82 to 0.9 range for PET flow and flow reserve. So it's really very exciting. There was one paper that suggested that perhaps the variation was really great, and using a Monte Carlo simulation from Ann Arbor, Vank Murthy raised appropriate questions about that. But the subsequent work that came out from the Brigham looking at the spline fitting approach to analyzing the data seems to have taken out some of that variability. And in fact, as Dr. Ruddy showed in our All About Flow Symposium at ASNC 2022 in Orlando, the use of this spline fitting really brings CCT SPECT reproducibility very close to that of PET. The major innovation that we're still waiting for, as you definitely know, Ricardo, is the ability to do motion correction with flow. That is technically a push of a button and a 5-minute operation using PET. We don't quite have that. We're hoping that there'll be we're told there will be software advances sometime this year to help with that portion. Once we get automated flow correction, which is harder, right? Because we have many fewer counts doing blood flow with SPECT, it should really make it much more consistent. So stay tuned, but we already have published meta-analyses of the diagnostic value of MBF with SPECT flow, CCT SPECT flow, as well as one published paper on prognosis, which is compelling, and another one that's impressed. So stay tuned. I think you're going to be hearing a lot more about it.
Wow, I mean, that sounds like you're on the cutting edge of pushing this technology forward. Now, I'm run a little shop, and I'm looking to replace my aging conventional camera. I do perfusion imaging. That's what I do day in and day out. What kind of training am I going to need to be able to use this fancy new camera? Can you teach an old dog new tricks? How do I know how long I'm supposed to image the patient? What doses am I supposed to use? Are the pictures, do they look the same? Can you help me out with those really practical questions for our members?
Those are good questions, Lane. The images look very sharp. The spatial resolution of CCT SPECT approaches that of PET. And so, as a matter of fact, if you compare CCT SPECT MIBI images to rubidium PET images, people think that the SPECT images are the PET because of the higher resolutions. So the images look sharp. They're a little bit noisier. And there is a need for two-position imaging, supine and upright, analogous to supine and prone that we're used to from the literature, taking the best counts in any region between the two pair of two images to score. But using quantitative software and using this emission attenuation AI application, it's striking how easy it is to read them. There is obviously a learning curve no matter what you do, but the payoff is that you're going to be able to double your productivity roughly compared to a sodium iodide camera. And I think those of us who have made the switch and braved it, we're now in our 11th year or 12th year of using the Spectrum Dynamics camera. You wouldn't want to go back. The images are clear, they're sharp. The ability to do blood flow gating, as well as expanding the entire armamentarium, it's going to improve your throughput. And I think it's a good economic investment, which will not only enable you to do much more perfusion imaging, but more metabolic imaging and other applications that are, at the heart of the future of the field.
So what is your typical imaging protocol that you use on a perfusion patient? What kind of activity are you using, and how long are you imaging for rest and stress?
It's a great question. you can do a stress only exercise test, for example, with 5 millicuries of sestamibbe, which is an exposure of 1.25 millisieverts, which is lower than PET or CT, and get diagnostic high quality images. Randy was using those from Mid-America for years, which convinced us of the value of it. We think that we use a sliding scale in terms of weight. We do weight-based dosing. We go for about 1 million counts in the region of interest, and it's very easy to obtain that. The hardest patients to image are those who have a dilated cardiomyopathy, because it's a small field of view camera. It depends on the camera you use, but no matter what camera you use, it's still challenging to get the heart. You have to make sure through a pre-scan, which can take as little as 10 seconds, but you may want to spend a minute making sure you've got the entire image in the center of the camera. That's the biggest challenge. So you can use low dose in younger patients and image them for longer periods of time. In general, using half-dose imaging or full-dose imaging with obese patients, we're done imaging with as little as 2 minutes. We don't go less than 2 minutes of imaging. That's for each supine and upright image. But we frequently have imaging that's 5 minutes or less for stress, and it can take a little bit longer for resting imaging. But compared to routine sodium iodide imaging, it's much faster with much lower doses, and ultra low dose imaging is possible. We usually use pretty standard doses for the very morbidly obese. These are people north of 40 or 50 BMI, and you can get excellent quality images even at those levels of BMI with this high sensitivity camera. The detectors themselves, it's a good board question for the trainees, are not that much more sensitive than sodium iodide, but the fact is they're so miniaturized that you have many more detectors. So for example, with the SPECT, there are 9 oscillating detectors. That's a spectrum dynamics camera with a parallel hole collimation. For the GE 570C camera, there's 19 fixed detectors with pinhole collimation. So it has a little bit better spatial resolution, but at the cost of some sensitivity with the use of all those. With the Spectrum Dynamics Veriton, there's actually 12 oscillating detectors, and each detector has 8 CZT modules per detector. So you get a very robust, very substantial count. So counts are usually plentiful, and the quality of the imaging is really excellent.
Oh, that's great. Ricardo, what do you have to finish things off here today?
I think this has been fascinating, all the information and the future of what SPECT imaging holds for us. One of the things this question is, there's been a lot of focus on amyloid imaging in particular, and amyloid just in general, PYP imaging. Can SPECT offer some further insights of CZT SPECT cameras in particular when it comes to amyloid imaging?
Yeah, it's hard. It's a great question, Ricardo, and I think it's hard to beat the history over the past 7 years in the literature of routine SPECT imaging for amyloid. But using this CEDARS technique of dual isotope imaging, I have to say, CZT imaging provides an advantage in terms of being able to complete the imaging in about 90 minutes as opposed to 4 hours. And we have never, ever, in the several years that we've been doing amyloid imaging, we've done over 400 cases here in Rochester. We've never had to go longer than 90 minutes. We played with 60 minutes for a while. We thought the quality was a little borderline in cases, so we thought 90 minutes was the right approach. But the ability to use the myocardium itself through a low dose of a second tracer as the gold standard, that you're comparing the metabolic uptake of the PYP or the HMDP, to me makes a lot of sense. It's a real paradigm shift. Rather than comparing it to contralateral lung, which has its own issues in terms of quantitation, or rib, which could be hot or cold, or have a hot spot, which could interfere with the quantitation relative to the rib. So I think the sense that we have here at Rochester is we have great confidence in every case. We just are no longer scratching our head. Is it 1+ or 2+? That used to be a big question. When we went to the dual isotope asynchronous imaging, we really stopped asking that question. We have such excellent resolution and definition of myocardial versus LV cavity activity.
Wow. That's great information on CZT SPECT, its current role and its future potential. I want to thank you, Dr. Schwartz, for being here for this 9th installment of our ASNC interview series. And I think you really wonderfully covered our topic of expanding our diagnostic capabilities with CZT SPECT. Thank you so much for your time today.
Thank you, gentlemen.